Good evening, everyone. And uh, it was a wonderful presentation and wonderful post discussion. Actually, Sir has given a comprehensive overview of the treatment protocols in both the cancers we have been hearing since morning, and we had a wonderful discussion later on about the testing perspective. So I'll just not repeat what we have discussed so far, but just pinpoint some of the testing perspectives in these two cancers. So, as we know that in ovarian, majorly in breast and ovarian cancers, we have a hereditary component, which is about 8 to 10% of cancers which are hereditary, and this pedigree actually depicts the same. It is a family where 3 generations are affected with different types of cancers, as you can see, and both male and females are affected. And while testing was done, they were BRCA positive. So basically, if you see that genetic testing holds very important space in cancer treatment, as well as to understand the genetic predisposition to these diseases. And we do genomic testing for risk stratification to understand the genetic predisposition. For diagnosis, prognosis, and treatment selection, as Sir has rightly mentioned, so many biomarker-driven therapies are available. For those, biomarker needs to be tested, and that is done through genetic testing. Then, after the treatment is done, we do see resistance to therapies, and there also we need genetic testing to monitor the treatment, to find out why the drug resistance is happening, what is the recurrence, to find out minimal residual disease, and to, of course, enroll the patients in the ongoing clinical trials. So that is all why we require genomic testing in cancer. And genomic testing can range from different types of genetic abnormalities across the organization of genome. Genome, the most condensed form is chromosome, and we can see the abnormalities at the chromosome level, which can be gross, microscopic abnormalities, which can be structural or numerical abnormalities. Then it can be submicroscopic, leading to maybe a single arm of chromosome deletion, duplication, translocations that can be detected through microarrays, FISH, or RT-PCRs. Or if we go a little bit more to the open space, where towards the DNA, we see exonic level deletions or duplications, or basically gene or multi-gene level deletions, duplications, which can be detected through MLPA, exon array, FISH, and next generation sequencing. Here, next generation sequencing holds little bit lower sensitivity because it is a short read sequencing method. But when we come to the base level at the DNA, when we are looking at the nucleotide sequence of the DNA, then next generation sequencing is much more sensitive than any other technique. So these genetic abnormalities, what we talk, they can be present as germline variants, or they can be present as somatic or acquired during the lifetime. So if they are germline, they are present in all the cells of the body, and they will be inherited in the family. So children will be at risk of carrying these variants, and therefore it is important to determine these germline variants, whether the cancer is germline predisposed. When the cancer develops through some acquired mutations, these are called as somatic mutations, and these we usually detect when we do localized tumor testing or liquid biopsy testing, because that particular area will represent those mutations, those acquired mutations. So coming on to the ovarian cancer, as we have already heard a lot that genetic testing holds a lot of importance in ovarian cancer to determine, first of all, as risk stratification. If there is any ovarian cancer patient walks up to the clinic with personal history of ovarian cancer at any age, as per the guidelines, should be offered germline genetic testing. Plus, it should be the patient should be offered HRT testing or somatic BRCA1, BRCA2 testing. Now the question is like whether you should do germline testing first or you should do tumor testing first. So ASCO 2022 guidelines have clearly shown that all women with EOC, when tumor first approach was used, the time as well as the cost and as well as the number of the patients were increased with some pathogenic mutations in BRCA when they were tested on tumor first. Why? Because 15% of ovarian cancer patients may present with germline mutations. However, there are 7% more which can have somatic mutations. So if we will do germline test first and then go for somatic test for BRCA1 and BRCA2, we will have a longer timeline, plus we may miss if we do not do the test on tumor. Another important point that was noted in some literature and some studies and in some tertiary centers was that if you counsel the patient for germline test first, the compliance and the comeback may be lower. But if you do a tumor test first, and only those patients who are having a BRCA mutation on the tumor or HRR mutations on the tumor will be counseled for germline mutations, then the comeback and the compliance will be more. So that's how the tumor first approach has been encouraged in ovarian cancer patients. And in tumor first approach, not only BRCA1 and BRCA2, but we have tests available which can test HRD as well as BRCA1 and BRCA2 simultaneously. So that's what in ovarian cancer patients, the tumor should be tested for HRD as well as BRCA1, BRCA2, which will give us HRD status as well as which will give us BRCA1, BRCA2 status, which can then be confirmed whether it is germline or not on the blood of the patient. And therefore, this is the basic algorithm of the testing that we have. So if we look at HRD, why do we want to do HRD but not only BRCA1 and BRCA2 or HRR? Because we would like to look at the consequence, which will actually identify those 50% of the patients, high-grade serous ovarian cancer patients, which has HRD phenotype. But if we will look at the cause only, because the cause is not only BRCA1 and BRCA2 mutation, causes are some other causes also which are beyond the scope of NGS, or for which we don't know the causes, but there is a HRD phenotype in 50% of high-grade ovarian serous cancers. So looking at only BRCA1 and BRCA2 will miss few patients, about 20-25% of patients which are HRD high, but due to some other cause. So that's why we would like to do HRD instead of only BRCA1 and BRCA2 on tumor first approach. So this was the main thing that I wanted to highlight, and Medgenome is offering HRD track test which has been developed at Medgenome. We are not using off-the-shelf commercial kits. It has been developed and validated at Medgenome on 200 plus clinical samples, reference standards, healthy controls, as well as we have validated it with FDA approved Myriad choice, and we have got 100% concordance. The overall accuracy is about 97% in clinical samples. And we have tested almost 1500 plus patients using this test, and this is developed in collaboration with AstraZeneca, and we find HRD positivity rate of about 52%, and where the QC pass percentage in post-analytical state is about 95%. So this is where we stand in comparison to off-the-shelf panels. This is a report example. We give HRD recombination deficiency status, which is basically based on genome aberration score, that is AI based algorithm which uses CME profiling, and it is either or based on BRCA1 and BRCA2 mutation status. So even if BRCA1 BRCA2 mutation status is negative and genome aberration score is high, still the patient would be HRD high, and the cutoff for that is about 40. So these are different scenarios where tumor BRCA was negative, however GA score was positive, or sometimes we do not get BRCA status because due to the poor FFP quality of DNA, the coverage of the BRCA genes can be poor, but still we can get GAS score. So those kind of scenarios also we do see. So this was about ovarian cancer, and one important point which was discussed in the previous discussion that I would like to again mention here is that, of course, the importance of comprehensive tumor profiling. Comprehensive tumor profiling will include about 500 genes, TMB and MSI status, as well as HRD. So basically, it will give us the entire genomic profile of the tumor, which will help us to take treatment decisions more judiciously. And I wouldn't go more into endometrial cancers. We have already seen the classifications and the treatment perspective according to the molecular classification. Only thing that I would like to highlight here is about the testing methodology. So POL is a gene which can be tested by next generation sequencing, or nowadays there is a qPCR kind of test also which will test those 11 pathogenic mutations in POL. So it is very important when we are testing the POL gene sequencing, the assay should cover those 11 pathogenic mutations, not only some of the exons of the POL. So next generation sequencing is the only method as of now to test POL gene. And for MMR and MSI, as per CAP 2022 guidelines, DMMR by IHC should be done. However, MSI by PCR looks at the changes in the sequence of microsatellite regions, and it will actually give us the phenotype or the consequence. So MSI by PCR is equally good. And in some tests, we also have germline mutation analysis for those 4 MMR genes: MLH1, MSH2, MSH6, and PMS2. So those genes mutation sequencing will inform if there is any Lynch syndrome association. So that is also important to check. And TP53 can be checked by MMR by IHC or by sequencing. There is about 5 to 8% of discordance reported in literature between TP53 by IHC or TP53 by sequencing. So sometimes we may see loss of expression of TP53, but we may not get any missense mutations on NGS. So in those cases, if we do not find anything else, then MMR by TP53 by IHC should be used to confirm the status if there is a doubt about it. And then comprehensive tumor profiling will include NTRK fusions, RET fusions, which are tumor agnostic markers now, and drugs are available. ERPR, HER2, of course, hormone status or HER2 negative status that we would like to see for endometrial cancer. And again, PRAF is a tumor agnostic marker, so it would be covered in comprehensive tumor profiling. So just to end up with some of the data that we had collected at our lab, so total samples, about 109 samples of endometrial cancer we just looked at the data for, and this is the stratification of POL mutated, MMR deficient, P53 mutated or P53 wild type with respect to their grades, with respect to the FIGO grade classification that we are trying to do. We are following up on the clinical follow-up of these patients with the clinicians, and we would come up with the next state as well. So another very important point about breast and ovarian cancer is that with respect to the family history and age or NCCN guidelines of testing, so if we look at the patients without family history of cancer, or young patients or older patients basically, then also we see that pathogenic BRCA1, BRCA2 or non-BRCA variants, pathogenic variants can be detected. So in this data, if you see, there is 271 patients for which we have looked at the data which were without any family history of cancer, and about 16% of HBOC patients were having likely pathogenic variant, and 27% of them were in the age group of less than 30, but there were about 15.6% of patients which were above 50 years of age. And if you see the distribution of the genes, then there were 27% of the patients who had non-BRCA pathogenic mutations. So this is an important piece of data which indicates that multi-gene panel should be used, and it should be used irrespective of age or family history of the patient. Another important point is that there are not only single nucleotide variations or small insertions deletions which are reported in these tumor suppressor genes. Large genomic rearrangements in BRCA or other tumor suppressor genes are also reported, and the percentage of these variants, large genomic rearrangements, they vary by population. So if you see Dutch population, or if you see European French populations, they are about having 10% or more than 10% of these type of variations. However, in Asian it is 3 to 5%. In our lab also, because we have an assay with MLPA, so we also see about 2 to 5% of patients who can have large genomic rearrangements. So NGS could miss these 2 to 5% of patients which have large genomic rearrangements in BRCA1 or BRCA2 gene. So the comprehensive comprehensive hereditary cancer panel that we do, it actually does MLPA also along with next generation sequencing, so that we do not miss out on these large deletions and duplications. And this is one case where there is a strong family history but NGS results were negative, and when MLPA was done, there is a deletion of exon 1, 2, 3. And usually, NGS will miss out on single exonic, very small deletions, which is pertaining to 1, 2, 3, 1, 2, 5 exons. If it is a whole gene or if it is a multi-exonic deletion, still NGS has the sensitivity, but for smaller single exonic deletions it may miss out on. So this patient was identified with this particular deletion through MLPA. So earlier, reflex MLPA was usually used if there is a very strong family history and a strong suspicion of hereditary component. However, comprehensive hereditary cancer panel that we present has MLPA integrated with it. And these are the various options that we are having. And genetic counseling is a very important aspect of any genetic testing. Pre-test counseling as well as post-test counseling should be imparted to the patient. Pre-test counseling should inform the purpose of the test, possible outcomes, and what could be the impact. And post-test counseling should discuss the results, the impact on the family members, as well as on the personal psychological counseling, as well as any follow-up has to be done. So these are the major things that we have to understand. And these are the key takeaways that tumor first approach in ovarian cancer should be followed. And HRD is a phenotype which should be tested over and above any other test in ovarian cancer. Thank you so much.